Welcome, ladies and gentlemen. Thank you for joining the Lake Superior Quality Innovation Network webinar, Check, Change, Control Cholesterol. Your host today is Andrea Busher. Please go ahead.
Good afternoon, everyone, and welcome to today's webinar presented by Lake Superior Quality Innovation Network. My name is Andrea Boucher. I am a Quality Program Manager at MPRO in Michigan, which represents Michigan in the Lake Superior Quality Innovation Network, comprised of Metastar in Wisconsin and also Stratus Health in Minnesota. Just a couple of housekeeping items before we begin. Today's webinar slides are going to be available on our Lake Superior Twin YouTube page within the next 2 weeks. So if you do have any questions during our presentation, please feel free to enter them into the chat box in the Q&A section on the right-hand side of your screen. We'll also have some time at the end of the presentation for phone questions. So at this time, I'd also like to introduce you to our co-host for today's event, Kristen Hurley, Senior Director of Multicultural Initiatives at the American Heart Association of Southeast Michigan. So welcome, Kristen.
Thank you so much. Hello, everyone. My name is Kristen Hurley, and I am the Senior Director of Multicultural Initiatives at the American Heart Association, Southeastern Michigan. Ours is an 11-state affiliate inclusive of North Dakota, South Dakota, Minnesota, Wisconsin, Michigan, Indiana, Illinois, Missouri, Kansas, Nebraska, and Iowa. And our affiliate, as well as an AHA across the nation, it is our community vision to orchestrate transformative change in communities. We hope to achieve this through providing leadership guided by our science to maximize resources and convene partners in building an equitable foundation of health. We are working to foster collective action that improves quality of life, increases opportunity, and ensures care for all our neighbors. It is our goal that every member of our community will be able to achieve well-being supported by the places they live, learn, work, play, pray, and heal. It is in furtherance of this vision that we are here today in partnership with the Lake Superior Quality Improvement Network to provide your clinical practice or organization the opportunity to provide science-based tools to improve health outcomes for our members of our community, thereby building a bridge toward transformative change and health impact in our communities. So at this time, we're going to move right into the program, starting with Dr. Maricela Castillo-McKenzie, who is a family medicine practitioner at the University of Michigan Family Medicine Clinic. So, Dr. Castillo, please go ahead. Thank you.
Hello. Hi, everybody. Thank you so much for the invitation. This is a very important topic, and it's very relevant to all the family physician and I think the medical community in general, because it's something that we see on a daily basis. So I'm going to be talking more about cardiovascular disease and stroke. So I'm going to give a little bit of background. We're going to go through some of the numbers, and we're going to specifically talk about the ASCVD risk score calculation too. So I'm going to start with giving you, the big picture of what's happening right now. As we know, heart disease encompasses coronary heart disease, hypertension, and stroke. And unfortunately, it continues to be the #1 cause of death in the United States. According to the American Heart Association and the American Stroke Association, in the 2017 Heart Disease and Stroke Statistical Report, there is about 92.1 million adults currently living with heart disease or the after effects of stroke. Cardiovascular disease accounts for almost 800,000 deaths in the U.S. each year, and is the leading cause of death globally. Coronary heart disease accounts for 1 in 7 deaths in the United States, and stroke accounts for 1 of every 20 deaths. Very high numbers, as you can see. As we move forward, we need to see what is contributing to these numbers and how to improve, high cholesterol identification and management. As we know, high cholesterol is a major risk factor for cardiovascular disease and stroke, which is #1 and #5 killer in the U.S. As we know, so far, 40% of the American adults have a total cholesterol which is equal or above 200 milligrams per deciliter. And about 1,200% of American adults have a total cholesterol which is equal or above to 240 milligrams per deciliter. The incidence of ASCVD events, ASCVD, which stands for atherosclerotic cardiovascular disease events, increases dramatically with each decade of life after 45 years of age in all sex and racial ethnic groups. There are several, effective strategies for primary care prevention of ASCVD. However, these strategies are often underused, and some high-risk patient groups are often undertreated. It's important to mention that these strategies are for primary prevention, not secondary prevention. So primary prevention is somebody who has not had any cardiovascular event yet. Recent estimates have projected that by 2035, nearly half of the U.S. population will have some form of cardiovascular disease. And of course, the cost of cardiovascular disease will increase from $550 billion in 2015 to $1.1 trillion, which is a very high number. Now, why does it matter? I'm going to show you some graphs right now, and for the first time in decades, we're seeing deaths from heart disease and stroke on the rise. As you can see from this graph, more people are dying from heart disease and stroke. On the left side of the graph, you can see heart disease, and you can see at the bottom we have the different years, and the left of the graph we have the age-adjusted deaths per 100,000 patients. So we can see how within the years 2015, 2016, we see that the deaths actually are increasing, whereas compared to previous years from 2017 to 2013, actually the deaths were decreasing. So this is a big, it's a big difference compared to previous years. And the same on your right-hand side of the graph, you can see for stroke, how in the years 2015 to 2016, the deaths provoked by stroke have increased compared to previous years from 2007 to 2013, where the deaths were decreasing. Now it's a big jump to increase deaths by stroke and heart disease. If we move forward, we can see in this map, the percent of obese adults by state. This is the map from 1990. When you can see in green, we have most of the states whose obesity rate was about 15 to 99%, so below 20%. You can see most of the states were, in that area, the green states. And only the Mississippi state, was above 20%. If we move forward, the map next, you're going to see how this is a map from 2015, and we can see how most of the map is in a red color. Red color meaning that the obesity rate has jumped to 30 to 35%. And there are some states where, obesity is even above 35%. We can see Mississippi, Alabama, Louisiana. So, this is alarming. This is a big problem that we're having, and I'm sure most of us know about obesity and what problem it has become to our patients and the society. So some important points to mention. Healthcare providers should assess atherosclerotic cardiovascular disease risk in adults using evidence-based tools such as the ASCVD calculator to identify those at elevated risk and might benefit from treatment. Cholesterol, which is a main modifiable risk factor, should be considered along with other health and lifestyle factors when assessing and calculating ASCVD risk. Statins are the first-line agents used to decrease cholesterol and reduce the risk of ASCVD events. Evidence supports their use in 4 adult groups with demonstrated benefit, which we're going to talk about. Statin therapy is safe when used properly and monitored. Engage patients in the discussion before initiating statin therapy and when discussing lifestyle changes. Initiate the appropriate intensity of statin therapy to reduce ASCVD risk and regularly monitor patients for adherence to lifestyle and appropriate intensity of statin therapy. Evidence does not support treating to a specific LDL or non-HDL target. Non-statin drug therapy may be considered in combination on or as monotherapy in selected individuals. Moving forward, the ASCVD risk assessment guidelines. These are 4 guidelines which cover risk assessment, treatment of blood cholesterol, lifestyle management, and obesity management. While all 4 guidelines are important for the prevention of ASCVD, the following focuses on risk assessment and cholesterol management recommendations for primary prevention for those with elevated risk of or high cholesterol levels. As I mentioned, it's primary prevention, somebody who has not had a CVD event. Understand ASCVD risk assessment and the use of tools such as the ASCVD risk calculator. These are some of the points that we are going to talk about. Understand also when and how to prescribe and manage statins. Understand how to prescribe and manage lifestyle, and overcome common barriers to treatment. Okay, talking more about ASCVD risk assessment guidelines. The 2013 American College of Cardiology and American Heart Association guidelines on the assessment of cardiovascular risk outlines recommendations for estimating atherosclerotic disease risk. Included in these guidelines is the ASCVD risk calculator, an easy and useful tool to help identify patients at risk for heart attack and strokes who might benefit from preventive treatment. Note that the ASCVD risk calculator is for use to identify patients who would benefit from primary prevention strategies, not secondary. The ASCVD risk calculator calculates risk using only a specific set of factors, which include sex, race, total cholesterol, HDL cholesterol, systolic blood pressure, history of diabetes, smoking status, and treatment for blood pressure. These factors assist in identifying patients who have not had a prior ASCVD event and assign a 10-year risk score. Patients are considered to be at elevated risk if the 10-year risk score is above or equals 7.5%. When to use this calculator? Patients 40 to 79 years of age without ASCVD, patients with LDL levels 70 to 189 milligrams per deciliter without ASCVD and not on statin therapy. When not to use this calculator, not for patients who are younger than 40 years old or older than 79 years old, not for patients with established ASCVD or with symptoms suggestive or of CVD, not for patients on hemodialysis, not for patients with advanced congestive heart failure, not for subgroups of high-risk patients, such as those with familial hypercholesterolemia. Statins are a class of medications that inhibit production of cholesterol in the liver. Previous cholesterol guidelines emphasize the use of statin therapy to treat the target cholesterol levels. But the 2013 American College of Cardiology and American Heart Association guidelines on treating blood cholesterol focuses instead on the use of statin therapy to address the broader goal of reducing ASCVD risk and events. Now, the guideline recommendations include the use of statin therapy as first-line treatment not only for high cholesterol patients, but also for certain patients with known ASCVD or those with elevated risk for ASCVD. Before initiating statin treatment in any patient, it should be emphasized that the following lifestyle changes are critical to ASCVD prevention and cholesterol management, including following a heart-healthy diet, exercising regularly, quitting and avoiding tobacco use. The 2013 cholesterol treatment guidelines identified 4 major groups who will be the most likely to benefit from statin use. Those are adults with known ASCVD, adults with diabetes mellitus, age 40 to 79 years old, with an LDL level between 70 and 189, adults with LDL level of above 190 milligrams per deciliter, adults with LDL level of 70 to 189 milligrams per deciliter and a 7.5% or greater 10-year risk of developing ASCVD, middle clinical ASCVD or diabetes mellitus. The intensity of statin therapy is defined based on the average LDL response to a specific statin dose. High-intensity statin therapy reduces ASCVD events more than moderate-intensity therapy. But lower-intensity statin therapy has also been shown to reduce ASCVD events, although to a lesser degree. To ensure that patients receive the most benefit from statin therapy, patients should generally be treated with the maximum appropriate intensity of a statin that is tolerated by the patient, provided there are no contraindications or safety issues, such as drug-drug interactions. As you can see now, we have a chart which includes the high-intensity statin therapy, which is high intensity because it generally dose lowers the LDL on average by approximately 50%. Here we have atorvastatin for 80 milligrams and rosuvastatin 24 milligrams. Moderate intensity statin therapy is daily dose lowers LDL on average by approximately 30 to 50%. We have atorvastatin 20 milligrams, rosuvastatin 5 to 10 milligrams, simvastatin 20 to 40 milligrams, pravastatin 40 to 80 milligrams, rosuvastatin 40 milligrams, pravastatin XL 80 milligrams, pravastatin 40 milligrams BID, and pitavastatin 2 to 40 milligrams. And then we have the low-intensity statin therapy. This group daily dose lowers LDL on average by less than 30%. We have simvastatin 10 milligrams, pravastatin 10 to 20 milligrams, rosuvastatin 20 milligrams, rosuvastatin 20 to 40 milligrams, and pitavastatin 1 milligram. Statin side effects. There are key points to monitoring statin side effects which include first, review her healthy lifestyle habits. Always, before starting statin, we have to review this with the patient. Such as adherence, response to therapy from patient, adverse effects within 4 to 12 weeks following statin initiation, or change in therapy. Measure fasting lipid levels. Unless symptomatic, do not routinely monitor creatinine kinase levels. If ALT and or AST are equal or above 3 times upper level normal, decrease or stop statin and consider other causes of liver disease. Otherwise, when statin dose is optimized and AST and ALT are less or equal 3 times of upper level normal, liver enzymes do not need to be repeated. Screen for and treat type 2 diabetes according to current guidelines. Communicate risk. It's important to have a discussion with the patient of the magnitude of risks versus the loss of benefit from the statin. It is an integral part of the provider-patient relationship. Involving patients in the decision-making process to arrive at a solution may help increase their compliance with the treatment plan. Muscle complaints. One patient taking statins to report worsening muscle pain without delay. Reassure them that prompt attention to these symptoms can minimize and otherwise serious side effects. Liver complaints. If ALT and or AST are equal or above 3 times of upper level of normal, decrease or stop statin and consider other causes of liver disease. Otherwise, when statin dose is optimized and ALT and AST are below or equal 3 times upper level normal, liver enzymes do not need to be repeated. Diabetes. Statin treatment slightly increases the risk of developing diabetes. Lifestyle and risk. 3 critical components of a heart-healthy lifestyle that patients can modify are physical activity, nutrition, and smoking. These 3 factors are high impact. When a patient's activity levels are appropriate, when a patient is eating a healthy diet, and when a patient is not smoking. The benefits can be seen not only for hypercholesterolemia, but also for hypertension, diabetes, and ASCVD. Patient-centered care. 3 quick tips for providing patient-centered care. Respect the patient's voice preferences. needs, and values. Provide reliable and understandable information to the patient. Involve the patient's family and friends. And we can see here in the graph how it is all related. It is very important to assess the patient's priorities, to understand if the patient is not agreeable to take the medication or if he is agreeable. Determine recommendations. We need to explain this to the patients as well. Communicate risk and benefits of taking the medications and arrive at a shared decision. So it is the patient service care. It is a decision that is based on provider and patient feedback. Okay, and now I'm going to have Malka continue with the talk.
Thank you, Dr. Castillo, and thank you so much, everyone, for allowing me this time to speak to you about our very new and exciting initiative, Check, Change, Control Cholesterol. This is a new initiative that just got kicked off a couple of weeks ago. As you know, the AHA's mission is to build healthier lives free of cardiovascular disease and stroke. And to that end, we actually embark on Check, Change, Control Cholesterol. It is a national initiative sponsored by Sanofi and Regeneron to bring cholesterol management to the attention of patients as well as providers. We've heard this morning cholesterol is a major risk factor for cardiovascular disease and stroke as the number 1 and number 5 killers in the U.S. And if you're familiar with our other national initiatives on blood pressure, Target BP, Check, Change, Control it very much focuses on improving in-clinic practice for high cholesterol. Is how is it detected as well as managed. Next one, please. Okay, I think. Okay, there you go. The way that, again, it's very much like Target VP, it works. It's an in-clinic practice quality improvement program. Now, my apologies, I'm having issues with the slides. But as you can see, just like Dr. Castillo mentioned, Check, Change, Control Cholesterol really allows for patients and providers to assess the risk factor. Two of the online tools that we see here, one is the ACVD risk calculator, which Dr. Castillo pretty much discussed at length. It's an online tool that was developed in 2013 with the cholesterol guidelines. The risk factor, the risk calculator assesses risk for having a first-time cardiovascular or stroke event in the next 10 years. A risk of 7.5% or greater should prompt providers and patients to discuss lifestyle changes and further treatment options as needed. These two are online tools, and they're available for providers and patients to estimate their 10-year risk. And as you can see, those two can actually be accessed. The links are right below that. So who can actually be part of Check, Change, Control Cholesterol? Well, I'm sorry, who should, join Check, Change, Control Cholesterol? Well, some of the benefits is that there are national recognition annually. There's very much like a provider toolkit. There's also the patient toolkit, and there's a Part 4 means of certification for providers, such as continuing education. There is support from CHA field staff. Christian and other field staff members are well versed in the program and can actually, walk you through the process and help you make sure you get the recognition that you deserve for the work that's already being done, I'm sure. Patient and provider CVDs, risk calculators, again, they are available for your use. So how does a provider become recognized, or how does a site become recognized? Well, there are actually two levels of recognition for providers. And again, if you are familiar with Target VP, they're very similar in the sense that there's a participant award recognition, which basically recognizes any organization that registers and that that commits to incorporating the ACVD risk calculator if they haven't done so yet. Now, the Gold Award is reserved for organizations that submit a numerator in denominator information for MIPS 438 and achieve control rates of 70% or greater within their adult populations that they serve. Check engine cholesterol will expand to include more tiers and additional quality measures in future years. But I think this is really where we want to start. We want to start bringing attention to cholesterol management to both providers and patients. So these two levels would actually allow us to do that. 2018 data will be collected via Qualtrics. How are sites recognized for their achievement? Well, there's already a change in cholesterol website that's already been set up by AHA. So, once the registration and the submittal period ends in June, you actually are going to be able to see your name on that website. The national recognition would also occur at the AHA Scientific Sessions in November 2018. There is going to be a certificate that can be delivered either electronically or displayed within your practice for both the participation and goal levels. There is already an icon badge with AHA proclaimers stating that could be used internally and externally on web pages and social media. But there's also an opportunity for local press release templates for clinics. There's other additional recognition opportunities that can be discussed with your with AHA field staff. Now, again, this initiative just started a couple of weeks ago, so the portal, it's already open. It began on 35th. So if you're interested in joining this initiative, all you have to do is go in there. You can actually register and submit data as of now. The ability to register and submit data will be there until June 1st. After June 1st, we're going to close down the submittal data portion of that, and we're going to have to, however, registration will still continue to be opened on ongoing basis. Now, if you're interested in finding out more about septic control cholesterol, there is a website there. There you will find a lot of different resources that I like for you to take a look at the fact sheet that just really breaks down what the program entails. And there's also a data requirement PDF that allows you to see the required data that we're asking for. If you're familiar with MIPS 438, that's a lot of that data, that's really what you will need. There's also a user guide for submission that really breaks down the process, what is the data that you will need to register, and also any other questions that you may have as far as the submittal process, any additional dates or anything like that. And also, I'm just going to go ahead and remind you again that if you have any questions about the initiative, you can always go ahead and email us directly to changecholesterol@heart.org. But also, look to Christian and other staff members, AHA staff members, for any additional support. And then I'm going to go ahead and thank you again for allowing me this time to talk about septic control cholesterol. And I'm going to go ahead and turn it over to Andrea.
of the Department of Applied Epidemiology and Evaluation here at MPRO, and I'm going to be presenting on some data related to cholesterol awareness for you today. So just the data that we're going to be reviewing comes from the Behavioral Risk Factor Surveillance System. I'm sure many of you on the call today are familiar with this survey and what it does, but just to give you a little bit of background for those of you who aren't as familiar with it, the system collects health-related data from U.S. residents via telephone survey. Survey includes questions related to health-related risk factors, chronic health conditions, and use of preventive services. Sponsorship includes many divisions and organizations such as the CDC National Center for Chronic Disease Prevention and Health Promotion, and the Services Administration, and the Health Resources and Services Administration on Aging, and other organizations. And I tell you this so you know that this is a really complex system that has to meet the needs of many different organizations. So as we go through the questions and the data, in case you're wondering why certain questions were asked or why they were asked in a certain way, it's just because the needs of this survey need to meet so many different organizations. Data are collected in all 50 states as well as the District of Columbia and 3 U.S. territories, and more than 400,000 surveys are conducted each year, making it the largest continuously conducted health survey system in the world. So jumping right into the data, we're going to be reviewing the 3 questions that were asked on the 2015 survey related to cholesterol awareness. Adults who have ever had their blood cholesterol checked, with possible responses being yes or no. Adults who have had their blood pressure checked within the last 5 years, possible responses are checked in the past 5 years, not checked in the past 5 years, or never checked. And the third question, adults who have had their blood cholesterol checked and have been told it was high, with possible responses being yes or no. And we'll be looking at results from all 3 of these questions. There we go. Sorry, our slides didn't want to advance. Okay, so questions could be stratified by 5 different groups: gender, age, race, ethnicity, education attained, and household income. And you could also look at age-adjusted prevalence for all 3 questions. And we're going to be looking at all 3 of those questions from the previous slide by age-adjusted prevalence. And then we'll look at the question, adults who have had their blood pressure checked within the last 5 years, by gender, age group, and race ethnicity. So this first map shows national results for adults who have ever had their blood cholesterol checked, responding no. And these results are from the 2015 survey and are age-adjusted. And results have been divided into quartiles, 3 cut points that divide the data into 4 equal-sized groups. You can see that Michigan, with a percent of 19.7, and Minnesota, with a percent of 20.4, fell into the second lowest quartile, with a range of 18.9 to 20.6, while Wisconsin, with a percentage of 21.6, fell into the second highest quartile, with a range of 20.7 to 23.4. So all 3 states kind of fell into that middle range for this measure. This map shows national results for the question, adults who have had their blood cholesterol checked within the last 5 years. Again, results are from the 2015 survey and are age-adjusted and have been divided into those quartiles. Michigan's percentage of 70.0 and Minnesota's percentage of 75.8 fell into the second highest quartile, with a range of 75.8 to 78.1, while Wisconsin, with a percent of 74.7, fell into the second lowest quartile, with a range of 72.5 to 75.7. So again, our 3 states kind of fell into that middle range. This table shows the results to the same question as the map on the previous slide, except the data are crude as opposed to being age-adjusted and are broken down by gender. And one can see that there is a difference between males and females in terms of who has had their cholesterol checked in the past 5 years, with females showing a higher percentage. And this difference is statistically significant for those 2 groups. This map shows the data for males from the previous table. Michigan and Minnesota fell into the second highest quartile with a range of 75.6 to 78.2, while Wisconsin fell into the second lowest quartile with a range of 71.9 to 75.5. This table continues to show results to the question adults who have had their blood cholesterol checked within the last 5 years, but this time the data are crude and broken down by age group. As age increases, the percentage of that population who had their blood cholesterol checked within the last 5 years also increases for all 3 states. The percentages are particularly low for the 18 to 24-year-old age group in Minnesota and Wisconsin, where roughly a third of the surveyed population responded that they had their blood cholesterol checked within the last 5 years. It's possible that these lower percentages for the 18 to 24-year-old age group could be because they're just too young to have had their blood cholesterol checked within the last 5 years, or it could be because there's a missed opportunity in this particular age group. Either way, I think it might require a little bit more research into why we're seeing these differences for that population, and I'm sure some of you on the call may be able to offer some insight into why we're seeing this difference for this particular patient population. So how do the results for the 18 to 24-year-old age group in Michigan, Minnesota, and Wisconsin compare to the rest of the country? You can see that Minnesota and Wisconsin fall into the lowest quartile with a range of 31.3 to 35.8%, while Michigan falls into the second highest quartile with a range of 41.7 to 47%. And this comparison may partially answer the question we had from the previous slide where we were wondering why the percentage was particularly low in the 18 to 24-year-old age group. This map shows that Minnesota and Wisconsin fall into the lower end of the range and could possibly indicate that there might be a missed opportunity in those states for that age group. But again, many of you on the call today may be able to offer some insight into that particular population. This table continues to show results to the question adults who had their blood cholesterol checked within the last 5 years. But this time the data are crude and broken down by race and ethnicity, and I do want to note that I did not include all possible race ethnicity breakdowns that were available, just the ones where the greatest disparity was seen, and that was seen between the white, non-Hispanic, and Hispanic populations, particularly for Minnesota and Wisconsin. The differences seen between the white non-Hispanic, black non-Hispanic, and Hispanic populations are statistically significant for Minnesota and Wisconsin. So how do the results for the Hispanic population in Michigan, Minnesota, and Wisconsin compare to the rest of the country? Michigan fell into the second highest quartile with a range of 63.9 to 71.2%, while Minnesota and Wisconsin fell into the second lowest quartile with a range of 59.5 to 63.8%. Finally, this map looks at the percent of adults who have had their blood cholesterol checked and have been told it was high. This measure is age-adjusted. Minnesota and Wisconsin fall into the lowest quartile for this measure with a range of 27.1 to 30.6, while Michigan fell into the second highest quartile with a range of 31.9 to 33%.
Thank you, Liz. So I think we've seen some really good examples from both Liz and Dr. Castillo on how we can use population health data and the need for that to improve high cholesterol. So looking at that population level data and also leveraging the information that you can gather from your electronic health record can help providers identify and work with patients to manage more specific risk factors or combination of risk factors, and that can also help to improve patient outcomes. So we also had a lot of focus on the ASCVD risk estimator, and that is a really great tool that allows providers to estimate a patient's 10-year ASCVD risk by entering demographic information and clinical data. So that is really helpful for clinicians to forecast the potential impact on different interventions on patient risks. Also helps to reassess ASCVD risk at follow-up visits and also use the information to help with clinician and patient discussions on risk and risk-lowering interventions. So again, we really want to put an emphasis on the importance of looking at population health data and leveraging the data that you have available and using alerts and reminders to improve the quality of patient care and ultimately lead to better outcomes. So just in follow-up, we wanted to conclude with some resources that can be available to you in your practice. The American Heart Association and Lake Superior Quinn have many tools available for you. Lake Superior Quinn is creating a comprehensive package that includes trainings for your staff, including blood pressure competency training and videos on proper blood pressure technique. also tobacco cessation counseling training, and also other resources available from our national partners. So if you're interested in any of those packages, you can contact your Lake Superior consultant to receive assistance. So I'll turn it over to Kristen to talk about her resources.
Sure. So in follow-up to our presentation on check change control cholesterol, I wanted to announce that, if you have additional questions or, you're very excited about the program and you think that you will be registering for check change control cholesterol, we do have an introduction to the program webinar actually scheduled on February 27th at 1 p.m. Eastern Standard Time. So we will share that information after the call as well, but wanted to bring your attention to the fact that there's additional opportunities to get additional introduction to check change control cholesterol. Additionally, Malka mentioned during her presentation about a program called Target BP, which just briefly I'll share that Target BP is a national collaboration with the American Heart Association and the American Medical Association to reduce the number of Americans who have a heart attack and stroke by urging medical practices, health service organizations, and patients to prioritize blood pressure control. So it is a very similar program to the cholesterol initiative, but focused on the work that you all are doing around hypertension. And so should you have an interest in also working with us on your hypertension and receiving recognition, again, at the 2 levels that are also available for check change control cholesterol. So you get a recognition based on your participation in Target BP and submitting your data, as well as, and that's your first layer, a tier of participation recognition. And then that second tier is our gold level that you can also achieve based on your hypertension rates for reaching 70% control or 80% control independently. So wanted to share that information. So should anyone have any questions, you can certainly always gain more information by visiting www.heart.org. That is, where you could get information on the cholesterol program as well as Target BP. And you can also reach out to our local office here and to myself directly. We will share our contact information after the call should you be interested in reaching out. But that is what we have for resources. Do we want to do some Q&A?
Yeah. So, operator, at this time, if you could open up the lines for participants to call in. And if you do have any questions, you can feel free to enter them in the chat as well.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. Again, if you have a question at this time, please press the number 1 key on your telephone keypad.
So while we're waiting for participants to dial in, I just wanted to remind you that the slides will be available on our Lake Superior Twin YouTube page within the next week, and we will also have our evaluation questions pulled up at this time. So if you could please take a moment to fill those out and let us know how we did, we would greatly appreciate it.
Again, ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. Again, if you have a question, please press the number 1 key.
We do still have Dr. Castillo-McKenzie on the line as well as Malka. So if you have individual questions directly to them as well as Liz on our data presentation, so all our presenters are still here, so feel free to jump in with a question.
And WebEx, could you please pull out the evaluation at this time?
Okay, unfortunately, we do not have any callers in queue for questions.
All right, well, if there are no questions at this time, I just want to thank everyone for your time today and attending our webinar. As a reminder, those slides will be available on our YouTube page within the next week. So again, thank you for attending and thank you to all of our speakers. We hope you enjoyed today's webinar.
Thank you.
Thank you, ladies and gentlemen, for joining today's call. Your call has ended. Please go ahead and disconnect.